This is abdominal anatomy part 2 from StudyMEDIC. The first is about the esophagus. Is a muscular tube. Length is 25 centimeter, anatomically divided into three parts: cervical part, thoracic part, and abdominal part. Cervical starts at the level of cricoid cartilage, that is C6. Anteriorly, it is related with trachea, and recurrent laryngeal nerve is in between. Posteriorly, it's vertebra. This is in the cervical part. You can see this is esophagus, cervical part. It is starting at this. So the nerves are very much surrounding the esophagus. You can see anteriorly there is trachea. Esophagus is behind. So this is trachea, this is esophagus, this is nerve. You can see recurrent laryngeal nerves. They are in between trachea and esophagus. These are branches from the vagus nerve. This is vagus. This is sympathetic ganglion of vagus. This is inferior ganglion of vagus. So it is passing like this. Vagus is very much on the both sides. So right vagus, when it goes down, it goes to posterior, and left vagus comes on the anterior side. So this is the basic nerve, which is one is becoming posterior and one is becoming anterior. That is what the relation. Posterior vagus is this which has gone behind, is showing here. So thoracic part of the esophagus pierces the diaphragm 1 inch to the left. This is again and again the questions coming. VOA, vena cava 8, 10, 12. So esophagus is at the level of T10 or 7th left costal cartilage. The additional thing is costal cartilage is second. Anteriorly, if you try to see, anterior relation is again trachea, left main bronchus, brachicardium, left. Here is the thorax and all the things which are coming. Posterior vertebra, left side arch of aorta on the left side. This is on the left side arch of aorta. And lung, pleura, and left vagus. Right side there has to be azygous vein, lung, pleura. Abdominal esophagus is very short. It is this much length. You can see 4 to 5 centimeter is inside the abdomen. This part of esophagus is only covered by peritoneum anteriorly. Peritoneum is present only in the abdominal part. Anteriorly, it is closely related to gastric nerves. Anterior usually within this wall, posterior related to posteriorly. Constrictors of the esophagus, this is important: 15, 22, 27, 40. This is first cricoid, C, A, B, and this is C, A, B, D, diaphragmatic. First is cricoid. A, B, C, D is also there. A is the arch of aorta. The C, cricoid, is at the level of C6, 15 centimeter, 22 centimeter, 28, and 40. Arch of aorta is at 22 centimeter. Left bronchus is, so if you see, this is C6, this one is T4, T6, and then T10. So this is 2 vertebra, this is 4 vertebra, C6 to T4. This is longer, so 15, 22, 28, 40. It's like this. Basically these constrictors 15, 22, 28, 40, 22 or 28. So this is C, A, B, D. So it has to start from the cricoid, C6. E. Arch of aorta. L. Left main bronchus. So cricoid, arch of aorta, left bronchus, and diaphragmatic. Upper portion of this is supplied by inferior thyroid arteries. Middle portion by esophageal branches. So here you can see this much esophagus, this cervical. It gets blood supply from the inferior thyroid artery. So inferior thyroid artery which is a branch of thyrocervical trunk. The cervical is sub. Then the superior thyroid from external carotid artery. So middle portion is by the esophageal branch of aorta. Lower portion for the esophageal branch, left gastric. This is coming. Question is coming. Left gastric artery. Venous drainage, brachiocephalic veins. Upper part, middle go to azygos and hemiazygos. Lower part into left gastric and portal. Lower esophageal veins are liable to varices. So left gastric vein and portal vein. This is the lower esophagus where varices happen. Cervical part is innervated by recurrent laryngeal which was parallel. This is thoracic part by the vagus, innervated by atomic. Lymphatic drainage is also important. Question: cervical part go to deep cervical, thoracic part to mediastinal, abdominal part to celiac group of lymph nodes. Endoscopically, cardia is known by the Z line, which is 1 to 4 centimeter from anatomical 1 to 4 centimeter from anatomical gastroesophageal junction. Lower esophageal sphincter is a functional sphincter. Peritoneum is serous membrane, forms the lining of abdominal cavity. So this is about esophagus. Next, coming to peritoneum, it is the serous membrane. Serous layers of peritoneum. Outer layer of parietal peritoneum attached to the abdominal wall. Inner layer is to the visceral. Outer is of wall. Peritoneum is wrapped around the internal. Okay, potential space between the two layers. Peritoneal cavity filled with a small amount of serous, very small fluid. Sterile allows the two layers of peritoneum to slide freely. Peritoneal cavity. Usually it is around only 50 ml. When you try to open the abdomen, there has to be only 50 ml of the fluid as there. Peritoneal cavity can be divided into greater and lesser sacs. So there is greater sac and lesser sac. Here you can see blue colored. The greater sac comprises majority of peritoneal. Lesser sac, also known as omental bursa, is smaller, lies posterior to stomach. There is stomach and behind and lesser omentum. This is lesser omentum, this is stomach, this is lesser omentum, and this is liver, lesser omentum, this is greater omentum, and behind this is the blue colored is lesser sac, and yellow, and this is the upper abdomen. This is total greater sac. This upper and this is lower. Further divided into two compartments by the mesentery of the transverse colon. Here is the transverse colon mesentery, known as transverse mesocolon. Superior supracolic. This is red one is supracolic compartment. Transverse colon, it's having stomach, liver, and spleen. This is stomach, liver, spleen. Infracolic, transverse below small intestine, ascending colon. Infracolic compartment divided into left and right SS. Supracolic infracolon connected by the paracolic gutters, which is between the posterior. The omental bursa is connected with the greater sac through an opening epiploic foramina. This is the epiploic foramina. Omental bursa or lesser sac. Situated behind the free border of the hepatoduodenal ligament. Lesser omentum or the gastric hepatic is attached to the greater curvature of the stomach. This is attached to the lesser omentum. This is lesser omentum gastrohepatic is attached to the lesser curvature of stomach and liver. Here you can see this is lesser omentum and this is greater omentum. This is at the lesser curvature of the stomach and liver. This is greater curvature of stomach and liver, and this is transverse colon. So greater omentum, you can see the greater omentum or a gastrocolic hangs from the greater curvature of the stomach, loops and curving back to attach to the transverse colon. It is draped for front from the intestines like an apron and may serve as an insulating protective layer. The mesentery is a part of peritoneum that is attached to all the organs. Peritoneal recesses are of clinical importance in the spread of pathological and these fluids. Subphrenic abscess. These are pituitary lying below the diaphragm and may sides of collection of subphrenic abscess. Intrapituitary right anterior. This is located between right lobe of the liver and diaphragm. This is intraperitoneal space. Right posterior hepatorenal, or it is also called as Morrison's pouch. This is between the liver and the kidney. This is the pouch where fluids posterior surface of the right lobe of liver, anterior surface of the right kidney, and lower layer of coronary ligament of liver. Its most dependent position of peritoneal cavity is supine position and commonest site for development of subphrenic abscess. So this is the layer where subphrenic abscess, most dependent part. This is the question. Hepatorenal abscess, all Morrison's pouch. Hepatorenal abscess, Morrison's pouch. Recess. Left anterior it is same. So it is between Morrison's pouch located posterior surface of the posterior surface of right lobe of the liver. The liver has got the right lobe, its posterior surface, and anterior surface of the kidney, in between the kidney and liver, and lower layer of coronary ligament of liver. So liver has got coronary ligament, so that is the recess. Extraperitoneal right paraphrenic, and this is the space between the stomach. Stomach is completely covered with the peritoneum. From anterior posterior, it is a J-shaped in commonest shape and left situated in the left hypochondrium, epigastrium and umbilical region. Stomach has two orifices, two borders and two surfaces. Cardiac orifice situated at the junction of T10 and 1 inch to the left of midline. Then it has got pyloric orifice which is at the L1 level. This is the pyloric plane to the right of midline. Borders, lesser curvature and greater curvature. Surface, anterior surface is related to diaphragm, liver and anterior abdominal wall. Posterior surface of the stomach. This is asked most of the time. What is the structures behind the stomach bed? Left crus of the diaphragm. It is starting from above. Left suprarenal gland, left kidney, splenic artery, body of the pancreas. This is behind the stomach. Stomach is made up of several parts, and these are fundus, body, pyloric portion. Fundus is above the level of cardiac, body is between fundus and pyloric portion is distal to imaginary line. Pyloric part has three parts: pyloric antrum or proximal dilator part, pyloric canal, distal narrow part, and pyloric sphincter at the end. Sphincter is the end, antrum and canal. Lesser omentum attached to the lesser curvature, ligaments attached to the greater curvature, gastrophrenic. From stomach to the liver, from the stomach to the spleen, and stomach to colon. Along the lesser curvature, there is right and left gastric. This is on the left curvature, right and left gastroepiploic. From right gastroepiploic from the gastroduodenal, left gastroepiploic from the splenic artery. Fundus has got supply from the short gastric artery. Right and left gastric veins drains into portal vein. This is coming into portal vein, right and left gastric vein. Right gastric drains into supramesenteric vein. Stomach is innervated by greater splanchnic, sympathetic from greater splanchnic, parasympathetic from secretomotor from the vagus nerve. Lymphatic drainage of the stomach, up right to 1/3 of the stomach drains into lesser curved lymph node. These drains subpyloric. Left to 2/3, upper 2/3 drains into gastrosplenic and lower third drains into lymph node. All the lymph nodes of the stomach drains into subpyloric, retropyloric, and then into celiac lymph nodes. So ultimately drain into celiac lymph node. This is the shortest and widest, most fixed portion of small intestine from the C-type curve along the head of the pancreas. So this curved first part, no mesentery except for the first part of the duodenum. It's 2 inches long and begins at the level of L1 vertebra. First part is 2 inches. It is only mobile part of the duodenum and is covered anteriorly by peritoneum of the greater sac, posteriorly by peritoneum of the lesser sac. Second part, it is 3 inches. First is 2 inches long, second part is 3 inches along the descending vertical from L2 to L3. So first part is 2 inches along the L1 vertebra. Second part is from L1, the bile duct opens into where the bile duct usually unites with the pancreatic duct to form the ampulla of Vater, and both of them supply the head of pancreas and duodenum. Supraduodenal artery forms the gastroduodenal artery. Now this is the first part, second part. Now you see third part. duodenal papillae 1 inch above the major pupillae. So third part is the important. It is transverse and 4 inches length. It at this level, it is covered by peritoneum anteriorly inferiorly. Fourth part is 1 inch long, covered by the peritoneum. This is duodenal jejunal fracture. Ligament of Treitz has two parts: slip of striated muscle from the diaphragm at the esophageal opening, ending into connective tissue of celiac artery. Fibromuscular band from the region of celiac artery to duodenal flexure. Fibromuscular band from the region of celiac artery to duodenal flexure. Third and fourth parts of the duodenum. Bleeding above the ligament can cause hematemesis and melena. Bleeding below the ligament can cause melena if massive bleeding per rectum occurs. Blood supply by the branches of celiac trunk. Superior mesenteric artery, superior pancreaticoduodenal artery from gastroduodenal artery, inferior pancreaticoduodenal artery from superior mesenteric artery. So both of them supply the head of the pancreas. Superior duodenal artery from gastroduodenal artery. Jejunum. Now, jejunum and ileum are distal two parts of intestine. In contrast to the duodenum, they are intraperitoneal. They are attached to the posterior abdominal wall by the mesentery, double layer of peritoneum. The jejunum begins at the DJ fracture. There is no clear external demarcation between jejunum and ileum, although two parts are macroscopic different. At the junction, ileum invaginates into cecum to ileocecal wall. The arterial supply to the jejunum is from superior mesenteric artery, and superior mesenteric artery arises at the level of L1, immediately celiac trunk. Around 20 branches from the arcades. The branches anastomosed from the lobes, long and straight, are vasa recta. Venous drainage, superior mesenteric vein, all that. So, large intestine, it begins at the level of ileum, ileocecal wall, divided into cecum, appendix, ascending, hepatic, transverse, descending, pelvic, rectum, and canal. Features are they have got hostrations, appendix, epiloquic. Peritoneal coverings, ascending colon are covered on the front and sides. Then transverse colon has got a mesocolon, mobile, and two layers attached to each other, sigmoid colon and sigmoid mesocolon. This you can see here, the figure is important. This is ascending colon, this is hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon. Blood supply is most important. It is from the superior mesenteric artery. Superior mesenteric artery and whole of the right side of the colon, transverse colon, is near about giving supply to superior mesenteric artery, and inferior mesenteric artery is below. So what is there? There is ileocolic and right colic, and middle colic and left colic. There are right, left, middle colic. So right, middle colic and ileocolic is from the superior. Superior is having 3 supply and inferior is having only left colic. So whenever there is obstruction in this inferior colic artery, the blood is supplying to the whole of this through this artery of Drummond. From here, the blood is going to whole of this. So even if the inferior mesenteric artery is totally gangrenous or embolized and thrombosed something, so this superior mesenteric artery is taking care of total descending colon. This is up to upper rectum. Then middle rectum, from middle rectal artery, which is then branches from the internal iliac artery. So this part is having supply from left colic artery and ileocolic, then ileocolic, from ileocolic the appendicular artery is also there. From this ileocolic, if you get all this artery, superior mesenteric is applied to whole of this small bowel from duodenojejunal junction to this one. So superior mesenteric artery is a major blood supply. So sigmoid colon has sigmoid mesocolon, two limbs of meeting each other from the V-shaped mesentery. The common left ureter descends superior rectal artery blood supply. Right. Lymphatic drainage is proximal group. You can see lymphatic drainage has got proximal group attached to mesenteric, superior mesenteric, intermediate from ascending and all this. Cecum is situated right iliac fossa, about 1 cm. The features of cecum are, special feature of cecum, ileocecal orifice is there. Appendix situated in right iliac fossa, except subhepatic, 1 inch below the vesical wall. So if you see the positions, the most common position is retrocecal, pelvis is next common. If you see arterial supply, ileocecal artery, or it is also supplied over the ileocolic. Free border of the mesoappendix, venous drainage, abdomen, nerve supply. Peritoneal covering is from T10. Lymphatic drainage again. The kidneys are retroperitoneal in structure. Upper pole, lower border is T12. Right kidney, lower pole is L3. Upper pole, lower pole. Lower border T12, lower border L3. So you can see this is the kidneys. From behind, if you see this kidney pelvis, kidney is located 1 inch. Right kidney is little bit below. Hilum of the kidney from anterior to posterior. Vein, artery, and pelvis. This is anterior, and this is posterior. VAP. P is posterior, pelvis is posterior. It can be remembered by mnemonic VAP. You do know anterior surface of the kidney is approached for nephrectomy, while posterior approach for nephrolithotomy. So posterior attack for nephrolithotomy, anterior attack for nephrectomy. Suprarenal glands are located at the superior pole kidney, superior pole of the right kidney, and attached to not having peritoneum over there. Both the kidneys lie on the four muscles which are located posterior to them. Superiorly there is diaphragm, psoas major, psoas quadratus transfer, PQT. Instead of PQR, there is PQT, transverse abdominis. DPQT, QT, quadratus and transverse psoas. Iliacus is not there. Iliacus is very low. That's why four structures separate the muscle from the posterior surface of the kidney. So in between these muscles and the kidney, there are certain structures, subcostal vessels, 11th and 12th ribs in the left, 12th in the right, iliohypogastric and ilioinguinal nerves. This is from the arterial supply. Kidneys are supplied by the renal arteries. Left renal artery is again L1 level, while the right renal artery is little bit lower. Right renal artery is longer. Right renal artery is longer than left, and it passes behind inferior vena cava. Right renal artery is passing behind inferior vena cava. That's why the length is more. So right kidney is used for nephrectomy. Accessory renal artery may arise from the venous drainage. Renal drains into drains of inferior vena cava. Capsule. This is a question. Gyrotas fascia. It is prerenal capsule. Fascia transversalis reaches the kidney, splits into anterior posterior layers and posterior layer attached to vertebra. The two layers fuse, but not below the gyrotas fascia. Not below the gyrotas fascia. Includes the kidney, but not the adrenal gland. It does not include adrenal gland. Left kidney is higher than the right kidney. Rib resection, left kidney operation. Right nephrectomy is more than the left due to relation to the biliary duct. Second part of the duodenal ampulla of the suprarenal located upper pole of kidney. Right suprarenal is a pyramidal in shape, while left is semilunar. Left is semilunar. So they has got three branches, arteries. Suprarenal artery from inferior phrenic, middle from the abdominal aorta, and inferior suprarenal from the renal artery. Venous drainage is a signal drained by the single vein that lives through the hilum. Suprarenal vein drains into inferior vena cava. Drains into left renal, left suprarenal into left renal vein, just like gonadal veins. Left suprarenal to left renal and right into inferior vena cava. Ureter is again 25 to 30 centimeter, diameter is 6 millimeter. Here the obstruction is biliary junction, inlet, ischial spine, terminal. Ureter is abdominal part. Ureter descends behind the peritoneum. Pelvic part is 12.5 centimeter. Enters crossing bifurcation of the cavity. Then this is intramural part is 2 centimeter. And segmental supplies upper third ureter from renal artery, middle from gonadal artery and common iliac artery, lower by the vesicle, anterior in male and uterine in the female. So uterine artery is also supplying to tips of transverse process sacroiliac joint. So coming to inferior vena cava, this diagram is showing everything about IVC. You can see here is the linguinal ligament. So how it is shown, this is inguinal ligament, this is external iliac vein, this is internal iliac vein. They join together to form common iliac. So middle sacral is in between. At the level of L5, they join to form. It ascends directly up to the liver. So hepatic inferior vena cava. What happens at L5? Its formation. So at each level, there are vertebral veins. So L1 renal vein. This is renal vein. Suprarenal is directly inside, and left suprarenal into renal vein, left gonadal into renal vein, right gonadal is inferior vena cava, right suprarenal is inferior vena cava. This is the way. Right gonadal, right suprarenal inferior vena cava, left gonadal, left suprarenal, left renal vein. This like this. Now it ascends up. Left renal vein goes into front of aorta. So this is aorta, vein is in front, renal vein, aorta goes behind. Then portal vein drains blood from the gut to liver, forms at L1. So L1 is also a level of portal vein. So this is inferior vena cava, inferior phrenic vein. Hepatic veins, there are 3 hepatic veins which are going into liver. This is most important figure. Comparatively, this is coming from above downwards. If you see like this, it is entering into this diaphragm to abdomen to T12. Right side there is inferior vena cava, left side is aorta. These are the parallel, these are the branches paired. Inferior phrenic, suprarenal. Inferior phrenic is actually paired. Suprarenal is from this, here is suprarenal. Then at T12 level only, there is celiac artery. This superior suprarenal, middle suprarenal, and inferior from the renal, inferior. Then superior mesenteric artery, right renal artery goes behind. What happens? Here what was there? Renal vein is anterior. Now right renal artery is going behind the vein. Actually this is left renal vein is goes in front of the aorta. Yes, it means aorta is in front, aorta vena cava is in front and aorta is behind. So this renal artery is going behind this and vein is in front. Right renal artery is going behind IVC. Left renal artery has to be behind right left renal artery. So right renal artery is going behind the IVC. So left renal artery should be behind the renal vein. That is the thing. So how is this? Yes, vein is always in front. Anterior is the vein. So vena cava is front. So this renal vein is also front. Renal artery is behind. Then pelvis. And this is totally behind. Right renal is totally behind inferior vena cava. Then left renal vein. Vein is always in front. This is about, this question is coming. Right renal artery is going behind inferior vena cava. Left renal artery is going behind left renal vein. So vein is always, if you see, the vein is coming from here. If the vein is coming from here, it has to be in front of artery. This is the renal veins. So renal artery will be, this is renal vein. Vein, artery, pelvis. VAP, from anterior to posterior. So this is about. Then coming to T12 level celiac, L1 is superior mesenteric, then renal is also just below the L1, then L2 you get gonadal or second lumbar, L3 third lumbar or IMA, inferior mesenteric vein. At L4 there is division. So this is also a important thing. Portal vein is formed by superior mesenteric vein. This is like a superior mesenteric artery, and this superior mesenteric is a bigger vein collecting blood from all of the small intestine and ascending colon. And this is inferior mesenteric vein, which is smaller vein. Inferior mesenteric joins the splenic vein. Though splenic vein and inferior mesenteric vein join with the superior mesenteric vein. This is superior, this is inferior. This picture will give you exact. This is inferior. So this one is inferior mesenteric vein. This is superior mesenteric vein. Inferior meets with the splenic vein, and both of these they join to form the portal vein behind this pancreas, and they open, go inside left and right portal veins, right branch, left branch in the liver sinusoids. So these are the important figures in anatomy.